Welcome to our webinar today. I am really excited actually to host this webinar more than some of our more recent ones because this is an area that even for me required a lot of learning. I don't routinely manage chronic pain, especially as an emergency medicine doctor, but oh my gosh, in an era of bupe and methadone and pain clinics closing down and all kinds of changes for our patients' ability to access care, it is becoming more and more important that we know the best ways to approach chronic pain for our patients, whether you work in the acute care setting or in the outpatient setting, whether you're a navigator or a clinician, doesn't matter. So I'm really excited today to be joined by two amazing women who I coerced into being here with me. Just kidding. They are both volunteering of their time and expertise, and I'm really excited for you to learn from them. I'm Alicia Gonzalez. I'm the clinical training director here at California Bridge, and I am also an emergency medicine doctor in San Diego and Brawley, California. And I will hand it over to Rebecca. Go ahead and introduce yourself.
Hello, I'm Rebecca Trotzky. I work at LA General Medical Center in Los Angeles County. I am a family medicine trained physician, which means my anchoring was actually coming to addiction by way of pain and chronic pain management. So I am really excited to be a part of California Bridge, which really kind of spearheaded the quick start of addiction treatment, no wrong door throughout the state of California and really now nationally. So excited to be here and working with our colleagues on pain issues.
Awesome. And then a first-time guest for us here at California Bridge, Sunny, can you introduce yourself, please?
Hi, everyone. I'm Aishwarya Sharma. I am a family medicine trained physician. I actually trained in Cleveland Clinic in Metro Health. And then I made my way over here to Redding, California. So way NorCal. And I'm actually our medical director here for addiction medicine at the Redding Rancheria. And this is something that I fell in love with in residency and really enjoyed learning about how we can help our patients, in particular with the chronic pain, because I know all of us in family medicine in particular deal with that. And it's such a privilege to be able to be here and work with you guys and hopefully help answer some questions on chronic pain.
Yeah. So in case you're not familiar with us here at California Bridge, we are publicly funded by the state of California. This training, in fact, is funded by CDPH, the California Department of Public Health, and we work underneath the Public Health Institute here in California. And as a nonprofit organization, we don't have any financial disclosures. None of our speakers today do. But if we say brand names like Suboxone instead of buprenorphine or Narcan instead of naloxone, please know that it's not on purpose. We're trying to use generics, but we're all very used to saying what our patients say. So sometimes we might slip up and say brand names, but it's not with any intention. We don't have any financial disclosures. The original goal here at California Bridge, when we were founded, was to try to make good addiction care, low barrier access to medication for addiction treatment accessible to every ER in California by 2025. And I'm proud to say we are well on our way. We are so close to making this the norm. But what we all know is that within the bridge model, where we make that low barrier treatment accessible, we connect our patients to outgoing care in the community with a warm handoff with all of our navigator team. And then we really try to build a culture of harm reduction within that model. Something that we are still dealing with that we don't always talk about is then what happens when our patients have chronic pain or when a patient who's been on opioids written by their doctor for a long time, maybe they're not using illicit fentanyl, they've been using opioids for a long time. What about those patients? How does that fit into this full spectrum of opioid stewardship that we talk about a lot? So I do want to first mention a very quick caveat, which is that we are not going to talk about buprenorphine basics today. We are not going to talk about the pharmacokinetics or the quick start guide or any of that. If you're looking for that, we have that available online for you already. But today we are really going to talk more about chronic pain in general. But first, before we dive into that, I do want to ask both of you, why are we not using buprenorphine in the ED for patients with acute pain? Like we do talk about all those pharmacokinetics, the benefits of bupe, why it's better than some of our full agonist opioids for patients who are taking it chronically. Like, why is that not what we're using when somebody falls and breaks their arm or somebody has appendicitis? Like, why is that not our go-to drug in general?
Yeah, first of all, it can be a thing and it should be a thing depending on your situation. In general, in the ER, we're focused on managing acute suffering as quickly as possible. Buprenorphine does modulate that mu receptor and does help relieve suffering, just like all other opioid agonists. It can also be started at a very low dose, either by IV or in the poor man's county, we have had people swallowing our sublingual formulations to get a really small microgram dose of buprenorphine. But in countries like France, it is the go-to opioid of choice because of all the optimistic pharmacokinetics where you can't overdose on it. It is really quick acting, and it does have a good long-lasting relief. But in general, also my hospital is like, well, could you please use the medication that costs pennies rather than dollars a day? And so sometimes there's just that financial cost of our hospital systems.
All right, so it actually is an option, just in more the microgram level dosing, which maybe isn't accessible or easy for all of us to access, but it is a thing that is being done in other countries, and maybe we should all be expecting that to hit the US at some point. And that's great to know. So now let's pivot a little bit and talk more about chronic pain. I mean, this is not a thing that we talk a lot about at Bridge, but we are getting more and more questions about it. And I think it would be an honest statement to say that this can be a really challenging patient population. Like chronic pain is really difficult to manage in a lot of different ways. And it's getting worse in my perception as these like random clinics are either just shutting down or cutting patients who've been on, let's say, hydrocodone for 10 years, just cutting them off, like cutting them off of all opioids all of a sudden. And they're coming in the ED, for example, in a ton of pain. Talk to me a little bit about managing these patients. What are some things that we really want to think about when addressing that concern? Sunny, I don't know
So,
if you have time.
yeah, the base thing is that, if you have an opioid tolerant patient, we absolutely can use buprenorphine and we should use buprenorphine. The thing that I think a lot of people are scared about when it comes to buprenorphine is the simple fact that it's not a complicated initiation. It's actually quite simple. What you can do is you can take a 24-hour buprenorphine dose, which can vary depending on the patient. It can be 12 milligrams, 16 milligrams, sometimes even higher at 24 milligrams. And you can divide it into smaller, more frequent dosing. So if someone is coming in and you're trying to treat chronic pain, rather than giving them one dose of 16 milligrams to take once a day, for example, we can try to break it apart and say, you know what? Let's try 4 milligrams 4 times a day or 2 milligrams 4 times a day and see how that works for you. With the buprenorphine, our analgesic properties are pretty similar to some of the other kind of short acting medications where it's 4 to 6 hours. So dosing it, QID or even 5 times a day, which I've seen in practice and also done, is safe to do. And we can increase the dose based off of what their needs are. So, this is one of my biggest sells for buprenorphine for patients is that you don't have to be restricted or limited in the dosing. You can take an additional dose and say, you know what, my pain was really bad. I took an additional dose. I felt better. And then we can titrate that medicine accordingly. And then, of course, that's not to discredit our other multimodal analgesic, kind of toolkit. And that's going to include, of course, your NSAIDs and your acetaminophen and lidocaine patches and potentially gabapentin or, pregabalin products. I love using Voltaren gel and muscle rubs. I love to use diclofenac gel. All of these things I think are also helpful for pain. So adding that onto the buprenorphine is super helpful. And then lastly, if they continue to have breakthrough pain and you've maximized them on buprenorphine, which by the way has never happened to me in clinical practice, patients do really well on buprenorphine. They do not need breakthrough medication on top of the buprenorphine. But if that happens, worst case scenario, give the buprenorphine first, and then you can give a full agonist to help with breakthrough pain.
Awesome. So what I heard you say a couple of things, like multimodal and a bunch of different medications. I know when we were prepping for today, we talked a lot about setting up goals with your patients. Like, what are some of the most common things? I know we have a slide ready for this too, but some common things that you have to address when we're talking about doing pain management with our patients in general.
I mean, like everything in family medicine in particular, education, education, education. It is so important. Patients come in sometimes with unrealistic expectations. They think that they will be pain free. And so it's extremely important to kind of have a conversation and mitigate those expectations a little bit, because our point is not for them to be pain free. Our point is for them to be in functional enough pain that they can still continue to do the things that they enjoy in life. And so, if they're coming in with unrealistic expectations, it is extremely important that we are kind of, setting the tone and explaining what we think are safe pain management goals and achievable pain management goals. So that's extremely important. We also like to do something called like a pyramid slide for pain control. And what I mean by that is that everything is not always about medication. Especially here in California, we have patients that are interested in learning more about some of their other options. You know, acupuncture has been known to help, osteopathic manipulation has been known to help. I've had a patient in particular, she cut out all of the sugar in her diet, which was extremely hard to do. And all of her inflammation went with the sugar. And now she's controlling her pain simply with her diet. So, it is important to follow this stepwise approach. What we fall in the folly of is it's easier to give a quick acting opioid than it is to have that sometimes 30-minute conversation about what we can do in regards to steps for pain management. Medication should always be second or third line in the step process. It should never be the first line option.
Yeah. So what I'm hearing you say is things like, talking to our patients openly about how movement is medicine and maybe addressing some underlying, if there's behavioral health issues, depression, anxiety, loneliness, right? Things like that that might be contributing. And then knowing what to reach for first, knowing what to reach for second, and then understanding the role of their opioid medication as a breakthrough or severe pain med and not their only pain med, that it's really like a part of a bigger picture. And then you mentioned this, but just the importance of setting expectations. And I think that one of the things I know as an ED doc is that it takes me a lot of practice getting better at these phrases. But I heard you say a couple of things, including like talking to our patients about the goal being functional, right? Not zero pain, but a functional or tolerable level of pain. And saying that up front, right? That sometimes we don't get to zero, but my goal is for you to be able to enjoy your life. And it might take some time for you to heal. It might take some time for us to get this right. It's not going to be instantaneous the way that giving a full agonist opioid, maybe in the ER, for example, might be instantaneous, and that would be our main goal for the patients. Rebecca, I'm wondering, because you have brought up to me before, and this is a really important learning point, that patients who have chronic pain don't always think about themselves as having opioid use disorder, because we always jump to this word addiction, which is like a very specific word that I think carries a lot of stigma. And even just by definition, it has to do with more of the psychosocial downfall and consequences that come from substance use. But if somebody's on opioids for a long time, I mean, they're building tolerance, they could have withdrawal. Like, talk to me a little bit about that intersection of chronic pain and opioid use disorder, and how do you think about justifying those two things together in your clinical practice?
Yeah, often I try to understand the patient's understanding of their pain. So one thing to consider is our patients themselves have been managing pain with a variety of things for a long time. And so sometimes I can reframe it by just saying, like, congratulations, you have a new shoulder now. Like, before, when you were young, you sprained your ankle and a week later it got better, but now we're in a different stage of life and the shoulder has arthritis and now it's going to be painful and it's going to come and go. And our job is to help you live well with this pain. So really helping them move from that mental mindset of like, I'm going to take penicillin, the infection's gone, I'm going to take one opioid and it's gone. And then really help them understand, like, what is your relationship now to those opioids? Like, when do you take those opioids and for how long have you been taking those opioids? And can you pinpoint a time when you started having to need them every day? And tell me about that, right? So I kind of understand where their history is, talk to them about who else is in their household and helping them with their pain and seeing kind of what their description of that looks like. And that sounds like a very family medicine thing to do, but you can also do that pretty quickly within a minute or two in the ER and understand, okay, this person socially isolated has been taking opioids from a number of prescribers for 10 years. And at this point, regardless of what else is going on with their psychosocial history, they have a physical and perhaps some level of psychological dependence on that opioid. And I pivot the conversation really quickly to, we can have medication like buprenorphine, which is a safe and effective alternative that will help you with some of those cravings, help you with your mood, help stabilize the pain receptors in your brain so that you can live the life you want to live. And I really don't even at that point need somebody to say, yeah, I have a problem with opioids, or accept that they have an identity around those opioids. I just shift into a safer way to manage your complex pain. And often I'm calling it complex pain. Like, I don't need to tease out the exact percentage that's due to some pathology of pain versus pathology of psychology. So I can just say all of this together is called suffering, and we have great medication that's safe to alleviate your suffering. Here's some ideas. Let's work together on how that's going to fit with your life. And that's how I, like, within a minute or two, change that conversation in the ER. And if I'm following up in an outpatient setting, it's a little bit longer of a conversation, a little bit deeper dive, but that would need to happen to change the game plan for that patient, because we as providers own that responsibility of making a safe plan for that patient, no matter what has happened in that legacy of that patient's life.
Totally. That's really, really helpful. And I think just I want to highlight something you said, which is like, I don't need the patient to say this specific word, right? I don't need them to say, I have opioid use disorder, I have tolerance. Like they can call it chronic pain, they can call it suffering, but for us to holistically have the same goal as this patient and to understand that their body is dependent on this medicine in a physical way can at least get us to where we're going with a conversation that's a bit more open. There was a great question popped in the chat by Eileen Dorsey, and what she asks is, and I'm gonna wrap up her question into another question, if you will. She asked the question about opioid-induced hyperalgesia. So this idea that, like, right, patients who are on chronic opioids, they get that like hyperalgesic situation that they have, and their pain tolerance does physically end up being lower. They really need high doses. So I want to, before we dive into that little detail, but I'm gonna let you ruminate, talk to me a little bit about using buprenorphine for chronic pain in general. So I know, Sunny, that you mentioned that you can divide them into smaller doses, like anything, 2 mg, 4 mg, that can be smaller and more frequent. Talk to me about why bup is a good medicine for patients who have chronic pain and chronic suffering in general. What are some benefits, or what are some reasons that we would consider this a good medicine in this setting?
Absolutely. I am a big fan of buprenorphine. And I mean, data, studies, everything has shown that it is a safer agent than your full agonist opioids. So it can certainly be used for chronic pain and highly recommended to be used for chronic pain. Biggest things is anyone can prescribe, right? So it's a Schedule 3 medication. It can be called in over the phone. You don't need, there's still some kind of fallacies going on out there saying that we need an X waiver. You do not. Anyone can prescribe this medicine. It's safe for all ages. And this part is important. Kids, adolescents, elderly patients, pregnant patients, those that are breastfeeding, everyone can be on this medicine. And that part of it is extremely important because that is not the case with your full agonist opioids. Our formulations tend to vary, but it's just helpful because you have more options with buprenorphine. So you have the Suboxone, which is has an naloxone component, and it's essentially a film. It usually comes, in 2 mg, and you can cut it, or 4 mg, and you can cut it, which is super helpful. You've got Subutex, which is a dissolvable tablet without that naloxone component. In Suboxone, and this is something that I've seen some erroneous thinking through about in regards to the naloxone, that naloxone component is going to help with diversion. That's not the case. Honestly, Suboxone is really just helpful because it's a film that you can cut. So, the tablets are difficult to cut, the Subutex, but the Suboxone films, you could take a 2 mg film, a patient that maybe has not had high needs for opioids but does have chronic pain, and you can cut it into 4 pieces and say, you know what, we'll do 0.5 milligrams 4 times a day, and we'll see how that's helping you. So it's not really that, oh, the naloxone component is going to prevent diversion. That's truly not the case. It's more about what are the needs of your specific patient, and do you believe that they would be a good candidate for smaller dosing or lesser dosing than what's currently offered on the market. Then of course you've got patches, which are again a great option. They give you a lower dose of buprenorphine, but it's constant. However, with patches, you can have some breakthrough needs on top of the patches. So that's something to keep in mind. If you have patients that are on high doses of full agonist opioids, the patches may not end up cutting it for their pain. So you may have to go with one of the oral options. And then lastly, we do have long-acting injectable medications. Brixadi and Sublocade are the 2 big guys on the market. These also work super well, and we have a full lecture on these that'll be coming up. So I just want to hit on that just so you guys have something to also ruminate on.
Yeah, thank you for mentioning that. I do want to highlight, we do have a full lecture separate about those long-acting injectables, but I like what you're saying, that some of this is practical decision making. Like, bup is safe, it's a great medicine for controlling pain. We have these long-acting injectable versions, or these patches that give you kind of a constant low level. But when you order the Suboxone, the combo bup naloxone, it can be helpful because you can cut it. Like, patients can actually titrate up or down their dosing, which is a really practical piece of advice that I haven't really thought about too much, I'll be honest, as a ER doctor. So then talk to me a little bit about that transition. We mentioned the question that was asked in the chat about the hyperalgesia. Talk about patients, maybe Rebecca, you can talk about this. A patient who maybe doesn't take buprenorphine or who's on other chronic opioids, how successful is a conversion from a chronic, whatever, hydrocodone, oxycodone, et cetera, to buprenorphine in chronic pain? And what does that look like?
Yeah, for sure. I have two mental models that I have for my patients who we know are on prescribed opioids. One is, are they also using unregulated substances, unregulated opioids that they're getting on the street? And some of the phraseologies I'm using is something like, when your narco prescription isn't enough or you've run out, are you getting other medications from friends, family, or the street? And often I'm getting a yes. And even in a patient where I'm like, for sure, this patient's not doing any of that. When that is triggered as like, yeah, I'm getting unacquired or unregulated any kind of medication. Sometimes they think it's benzodiazepine, Xanax. Sometimes they think it's, even weed that they're getting in a pill form, something like this. I try to go on a higher dose conversion. So if you're basically using more than 50 morphine milliequivalents of prescribed regulated known opioids, or any amount of prescribed opioids plus miscellaneous, whatever you're getting from a friend, family, or on the street, I'm going to a higher dose, kind of like a quick start for addiction treatment, opioid use disorder, and then checking in pretty quickly with both of those sets of people to see how they're doing the next day. Because if I over gave them a higher dose than they would need to in buprenorphine, you can easily back down. They're going to feel a little sedated, maybe a little more nauseous than usual. It's not going to cause them to have respiratory depression. It's not going to cause a great deal of physical harm, but they might not feel as well as they could. And then if you're underdosing somebody, you're going to see some elements maybe of uncontrolled pain, or maybe some symptoms of some opioid withdrawal. So for my cross starts, I'm usually stopping short-acting opioids so that they have a period of metabolizing those short-acting opioids, usually overnight. And in the inpatient setting, I'm helping them with sleep. So trazodone or benzodiazepine just for the night so that they can comfortably rest, and give them all those multimodals. And then I'm going to usually a 16 or 24 milligram sublingual in the morning, and then dividing it out. Usually, since it's an 8 milligram, it's usually 8 TID. If they have a really high level of opioid use, and then I'm going to go to 16 TID in the hospital and then back it down in the outpatient setting. If somebody's just a very small person using a very small amount of opioids, and we've decided that that's still very harmful for them, then usually like half of a 2 milligram tablet, so 1 milligram BID is where I'm going to start. And it really is surprising. Sometimes I'm for sure somebody's going to be a high dose, or for sure somebody's going to be a low dose, and they surprise me. So it's all about having that patient-led dosing strategy, give them the comfort of owning that medication and that comfort of telling you how they're feeling on it, and then validate, like, yeah, that sounds like it's right. The only caveat on that is sometimes people underdose their buprenorphine, and then they're still using unregulated opioids. So I really want to pay attention to them making sure they're getting enough buprenorphine in their system, that they're not having cravings for opioids.
Yeah. So the idea here, I mean, we do have a protocol on this if you want to take a look at it in more detail, but the idea being that we don't want them to have to stop taking medications. This goes to the question that you asked in the chat, Eileen, but that we don't want to, and they have this hyperalgesia, like they're going to feel so terrible if we tell them you have to stop your medicine all the way and go into withdrawal. So you can slowly start buprenorphine and ramp up over a couple of days to sort of replace that opioid. And then now they're on a safer, non-sedating, medication after they've finished that transfer. And then there are different models for how many days you can take to do that, but slowly with increasing the bupe concentration in their body. What I'm hearing you say, Rebecca, is that is how we kind of mitigate that hyperalgesia, how awful they really would feel if we told them, hey, stop all the way so we can switch to this medicine. It gives them time to not experience so much suffering in the process. Is that sort of what you're getting at?
Yeah, and this is also some of the elegance of the long-acting injectables. I've had patients on between 400 and 600 morphine milliequivalents daily, even higher than that. And we've started at time 0 with Brixadi, and then given them like at time 12 to time 24 hours after sublingual buprenorphine, because that, and allowing them to continue on their opioids that they usually are given at home or in the hospital. And that has not resulted in precipitated withdrawal or any sort of uncomfortableness. And then by day 2, day 3, we're able to kind of de-escalate all of those opioids. There was a question in the chat also about what if you have maybe new uncontrolled pain or new high pain on top of that buprenorphine, what do you do? Again, it's always like once you've maxed out your multimodals, your non-opioids, and your bupe is already at a high dose, I usually add on hydromorphone. And again, that's a high affinity opioid that can layer on top of buprenorphine, provide some good analgesia. I am cautious about trying to avoid IV and like triggering that euphoria brain, rather than like PO allows it to last a little bit longer, comes on a little bit more gradually, and isn't as triggering for many of my patients. But I'm not in that acute pain setting so worried about that kind of stuff.
Yeah. Great. And then I saw there's also some questions in the chat about bupes sort of half-life and stuff. And I'll just address, in our other lectures, we go into a much deeper dive on buprenorphine pharmacokinetics, but it does have a very long half-life, which is great in the sense that it can manage that chronic pain and suffering and mitigate withdrawals and cravings for patients. But the rise and fall of the analgesic components, like the pain medication component, is a bit shorter, somewhere on the order of 4 or 6 hours. And so that's why a lot of patients will end up settling on some kind of regimen where they take it multiple times a day in smaller doses. So they're getting the same overall 24-hour dose, but they're getting the rise and fall of the analgesic benefit more often, which also is what we're doing in acute pain. That's what Rebecca was just saying. So you can also take somebody's, let's say that they're doing really well on 8 milligrams twice a day, and they break their arm. You can separate that buprenorphine into 4 milligrams 4 times a day. They're getting the same 16 milligrams over the course of the day, right? But they're just getting it a little bit more frequently to help with that pain control. So it's a really nuanced, I think, there have been a couple of questions in the chat we've been addressing as we go, but a lot of this is just going to be patient-centric, right? I mean, some of it is really just what is working for that patient, get them on medicines that feel safe, explain that pyramid of steps so that they know how to feel empowered to take the right medications when they need it. And so speaking of patient empowerment, I want to ask about 2 items that come up for me as an emergency doctor, and I always am not sure what I should be thinking about them. And certainly for any of our primary care clinicians out there, probably are thinking about this too. And the first one is this idea of pain contracts. Like I have a patient, they'll say I'm in pain management, or I have this pain contract. There's like this piece of paper in front of me. This human being is suffering. And I'm like, I've gone through lots of phases in my career where I feel like there were days where I was like, you have a pain contract, no opioids, right? And there were other days where I was like, this piece of paper is stupid. I want to rip it up. Like, you're suffering. I want to help you. So how am I supposed to be responding to those? And then for any of our outpatient providers out there, what advice would you give them? What would you say about these pain contracts?
That's such a real question. In the emergency room, I think if somebody is like, I have a pain contract, it should help like trigger in your brain, like, is there something else going on? Would this be an extra good candidate for buprenorphine? Is this patient able to kind of separate new pain from a flare of their chronic pain? And it does maybe just help you put, a mental model in place a little quicker. That could be a situation. But in general, I agree with you. They do not support patient-centered care in my world. I don't see them helping patients get access to care quicker. I don't see them helping physicians come up with a care plan quicker. It's generally put in place in the primary care world as a stipulation, either from the health plans or from your health system, saying this is the way we're going to help providers be safer. What it does develop is a checklist mental model of a provider, like, hey, you should let me know ahead of time before going somewhere else to get opioids. Hey, you should go to the same pharmacy so they know you well, so you don't have drug-drug interactions. It does have some like touch points and talk points that helps providers, but in terms of like changing a patient's behavior, it doesn't do anything. Like, we know maybe well-intentioned people are signing these contracts being like, I'm never going to do X, Y, Z. But when push comes to shove, they're going to do X, Y, and Z if they feel like they need to do it to manage their pain. So they're not necessarily changing behavior. And we have study after study showing that it's not changing patient behavior at all. So it is more of a regulatory thing and makes us feel better than actually providing better care.
Sure. All right. Same vein. What about your toxicology screening? So I'm a firm believer that in the emergency department, it's a rare case where that actually helps me, like as the person doing the emergency. But I'm wondering, in the outpatient setting, these also feel like it's kind of a contentious topic. And I know that in certain, depending on where you live, right, different states have rules about things. Like if a pregnant woman has a positive urine toxicology screening, they have to report it to child welfare services or whatever. Like these are not benign tests, but I can also understand wanting to make sure your patient's taking the medication you prescribed as a conversation piece and to be able to say, hey, what went wrong here? Like you tested positive for fentanyl. Tell me what happened. Talk about those. Talk about urine tox screenings in the chronic pain setting.
That's a great question. So, I mean, oftentimes, at least in the family medicine realm, we do have some administrative burden that we have to abide by. So, in my clinic, UTOXs are the standard of care. That was one of our requirements. And so, I often think to myself that Eutoxes are not to catch a patient, oh, I caught you, you're lying. Now you're done. I'm firing you. It's not to be punitive. And I think that's the fear, right? So my patients, they know my standard of practice. They know that whatever comes up on that Eutox, we're going to have a frank conversation about it. And it's open dialogue. And it honestly is to be used as a modality to help enhance the care that the patient is already receiving. It is, not to be punitive. It's not to be paternalistic. And it just, like you mentioned, Alicia, it opens that door for that conversation. It's important if we're going to, every clinic, every hospital, every outpatient center is going to vary in their administrative policies. So it's important to have a standard of, okay, when do you do it? Why do you do it? And what do you do with this information? Notoriously in office eutoxes are extremely unreliable. So if that's all you have is your in office eutox, that's not going to cut it for us. So it is important that if you are doing eutoxes, that we're making sure that we're getting accurate results and then having a conversation with the patient about what those results mean and how we can help support them going forward.
I'm going to push on that a little bit in a different way, which is the forensic sequela of having a positive urine toxicology result in your EMR is significant. So as a 30-year-old pregnant woman of color on Medicaid, if you have THC showing up twice in your primary care routine with an excellent doctor, it's going to have some vibes of a cross-covering 2 a.m. nurse in LND that might be really different based on your race, based on your class, and all these other things. So I am very cautious about when we get urine toxicologies and why we're getting them, and ensuring that we have very explicit downstream consent, like thinking of like what's the worst possible case scenario that could happen with this result, and then making sure that I disclose that to the person. And even in my note charting, like if this urine toxicology shows XYZ, there's, false positives, false negatives, it's non-diagnostic of use, it's non-diagnostic of a use disorder, and it should not be used as a forensic tool to, judge somebody or to do different care harms. There are definitely things that I've gained from urine toxicology, like why is this patient so diaphoretic? Oh, it's the benzos, and maybe they just forgot to tell me, maybe they felt uncomfortable about it, but it did have some utility. But I would also say it's caused a great deal of harm, and having an explicit consent as a part of the process, ensuring that we're talking to people about what is the harms that could happen, and when are we using it, why are we using it, and then who else is going to be able to see it. So for example, we do urine toxicology contingency management programs, and we have none of those resulted in the EMR for that very reason. So I do think it's an opportunity for some of us like-minded physicians to advocate at a higher level. If your clinician boss is saying you must do a contract, you must do urine tox before you prescribe buprenorphine, that's wrong. So do your practice and change the system as you go, which I think is the California Bridge way.
Yeah, that is the California Bridge way, probably summed up in the most beautiful paragraph I've ever heard. But if I could synthesize both of your comments in a way that I just love how you both keep talking about the patient. And I think this is a population where patients with chronic pain carry a lot of stigma, and all of us, myself included, have had negative interactions that maybe fuel some of these feelings, these visceral feelings that I have sometimes when I see those patients in the ER, and I'm sure for clinicians, it can be the same in the outpatient setting, but this idea of like returning agency to the human in front of you, like giving them a chance to say, okay, I'm actually not willing to do that urine toxicology screening, but since you were so open with me and gave me the chance to consent, like, can I tell you that I've been doing marijuana and I actually think I'm pregnant, and here's why I don't want to take that test today. And all of a sudden, you as a doctor have all the info that you needed, because like you said, Sunny, we're not out to catch patients. Like, we're not the police. We're out there to advocate for patients and to help them live their best life, to live well, to be healthy, whatever that means to them. And so if we can shift our focus, like using the urine toxicology screening as a tool that is an open conversation with your patient. I know that we've had Ed Pilar is a lecturer that visits with us a lot. And one of the times, I remember he said that sometimes his patients ask if they can please do a UTOX because they're really excited to show him their results. And that's okay too. Like, it should be a tool that is a decision, a conversation between the clinician and their patient. And that really just changes the lens from this like punitive law enforcement bucket, which is really not where physicians belong. That's not my job. Their job is important, my job is important, and they're different. But speaking of that agency, you were talking earlier about some patients like the microdosing and the cross tapering onto buprenorphine. And one question I forgot to ask at that time, you know, sometimes I think we don't have a choice. These clinics close down or patients get cut off from their opioids. But if that's not the case, when and who should we be switching off of chronic full agonist opioids? So if you're seeing a patient, you're a family practice doctor, you're a pain management specialist, who doesn't matter who you are, you're seeing a person, they've been on oxycodone, they've been on hydrocodone, they've been on methadone, they've been on whatever. Who are we switching to bupe? Why? When? Like we got the how down, but when? Who should we be doing it for? When do you make that decision? How do you make that decision?
That's a great question. And it's one that we often encounter, right? Who is going to be a patient that will be served well with buprenorphine versus who's a patient that can be left on their current regimen? And just like with everything else in the art of medicine, there isn't a black and white answer. But I think I can help at least a little bit about what patients should be switched versus who should stay on their current full agonist. So if you have a patient who's on their current regimen and they're very stable, and what do I mean by very stable? There's no signs of failure. They're not having multiple falls. They're not going to the ED for increased pain or signs of too much opioids, right? So confusion, altered mental status, multiple falls, multiple complaints of uncontrolled pain. Those are not patients that are stable on their current dose, right? However, if you have a patient that's on, say, 5 milligrams of oxycodone twice a day, they've been on that for the last 5 years, they've never asked for an increase, they've never asked for an early fill, that's a safe patient who can continue to be maintained on their regimen because they wouldn't really meet that DSM-5 criteria for OUD or necessarily need a change if they're doing well. That said, there are patients who often don't meet that criteria, right? There's a safety conversation that needs to happen. We have patients oftentimes that have chronic pain that are over 65. They have sleep apnea, they have heart failure, they have COPD, they have extreme amounts of risk for, respiratory depression and death. So those are patients where we should be having a conversation about, hey, let's put you on instead of a full agonist, a partial agonist opioid that's going to be better for you, better for your pain, better acting, and hopefully mitigate some of these risks that you're experiencing or may experience in the next, several days to several months. There's also, a conversation that should be had if you have a patient that it does meet treatment failure. They've gone to the ED multiple times, or they are coming in and they need early fills and they need increased dosing. Those are, again, patients that you should have a conversation and say, for safety reasons, I think we should switch to a buprenorphine product and let's see how you do. And then I kind of touched on this a little bit, but there is an actual DSM-5 criteria for OUD, which is extremely helpful, and it can kind of validate you in the eyes of insurance companies, right? Because we always play the insurance game in family medicine. So if you guys have a chance, look at that DSM-5 criteria. Take out the tolerability and the withdrawal question because those are not relevant when we're doing prescription-based opioids when you're looking at that questionnaire. And then just see if the patient hits that criteria. More often than not, you will find that they are hitting that criteria. But once again, the patients that should not be switched are those that are on a reasonable amount of opioids. Again, that's very subjective and is, bound to change from person to person. But they're very compliant with their medicine. They're not running out early. If that's the case, then maybe this is not a person you have to switch to buprenorphine. If they don't have that, high risk factor of having respiratory depression, they're not elderly, they're not, they don't have concurrent pulmonary issues, maybe this is a patient you just continue on their full agonist.
So if somebody is doing well and they're not like, say going to the ER for falls, they don't have multiple reasons to depress their respiratory status, like don't punish the patient that was started on this medication by some doctor however long ago, right? We're going to build a relationship with them and continue. But if their current regimen's not working for them, they're going to the ED a lot, they're running out early, maybe they are having multiple falls, maybe they are, at risk, they have COPD, they're on CPAP at night or whatever else, other hypoventilation syndrome, then maybe you have a safety conversation and think about transitioning that patient, which actually though then raises another question. And Rebecca, you're like my favorite doctor ethicist, even though you're not a professional ethicist. I just trust your gut on these things so much. So I'm wondering if you can talk to this. But um, what if I'm a family practice doc? I have a patient that has now fallen multiple times, and gone to the ER in the past month, and they've been on oxycodone or hydrocodone for ages, and they think they're well controlled, but they keep having falls or episodes where like aspiration or something. And I believe medically this is unsafe and that we should switch. But the patient maybe doesn't want to. Like, what happens then, right? I have an obligation to do the safe thing, to do no harm, but the patient's not necessarily on board. Like, I don't want to be paternalistic, but I also don't want to perpetuate something that I find unsafe. Like, how do I navigate that moment and that conversation with this patient, whether it's in the ER, in the hospital, or in the outpatient setting?
Yeah, I think gets right down to the meat of the matter for so many of us who've inherited the legacy of opioid overprescribing, which is every single patient I've ever met who has the option to choose full agonist opioids versus, hey, do you want to switch to something you've never tried before? It's called buprenorphine. Here's blah, 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 blah. They're going to choose like, can we please stick to the thing I know called Dilaudid or called Norco, whatever it is. It's very rare, and I cannot think of a time, in fact, where somebody's been like, yes, I want to switch. So just like everything else in medicine, it's our job to present safe options and not to present harmful options. So I'm not presenting an option that's like, hey, I've noticed you've overdosed 3 times and we've almost had anoxic brain injury each one of those times. Would you like to continue? I'm like, here's what we're doing. We're going to change this way or that way. Which way would you like to change? And giving them as much safe options as possible. And just to think, everybody looked like a great, well-controlled patient who was doing well on those opioids before they had the fall or before they had that car crash or before they had that anoxic brain injury moment. So it's really hard to pick who's going to do well and who's going to do unwell. And that's a feature of the opioid medications, right? That's why they're so dangerous. And it's not an individual person issue. It's a class of medication feature. So the more we can just provide safer options and switch over to buprenorphine for people who still want some opioid agonist feature, it's going to create a safer patient encounter and a safer community situation. And more, I've had patients calling me 3 months later being like, I thought you sucked on day 1. I was really frustrated. Let me tell you how much we were grating on each other's nerves that moment. But I'm so glad I made that change. Like, I am getting good sleep. I am moving in my life. I'm seeing my grandkids. I'm doing all the things I wanted to do. And it's because you really kind of helped me make that change in that transition. And that's what we're here for, right? I don't need my patients to love and like me on day 1. Like, they're obviously going to have that by day 10. No. But I do need them to be alive, and I do need them to be functioning well in their life. And so that's part of this complex conversation that we get to have. And, sometimes it's something that needs to happen really quickly. Like, this is a hospital, you came here, you overdosed, bad things happened, your renal function changed, we have to switch this medication. Sometimes it's something that can happen a little more gradually, maybe over months. But it has to happen. And it's a aching conversation sometimes in our hearts. And the more that we as providers can just feel comfortable and confident and like, this is a safe, effective analgesic, that's why I'm offering it to you. Not I'm punishing you for overusing opioids or you're a bad person with an addiction issue. Like, no. This is just the safest thing. And you're going to feel well and you're going to feel supported with this medication. And I think the more we can get comfortable saying that, the better off our patients are going to be.
Yeah, what I hear you saying is that we are making medical recommendations the same way that, like, when you have cellulitis, I say, here's the antibiotic that I'm recommending. And would you like to try ice packs and see what happens? Would you like to try, like, I'm saying, no, this is the medical treatment. And so offering it as, hey, I want to continue treating your pain and this current plan is not safe. Here is what I am offering. This is what we will do now going forward to take care of both of those items. And then, we talked a lot today about treating the one patient in front of you. And I think we should consider every life as unique and every patient's chronic pain plan as unique. But at the same time, we do have an obligation to stop the opioid crisis. We do. We have the responsibility has fallen to us, whether or not we have been in our career long enough to have been a part of it or not, we are all a part of it still. And so we do have this like larger obligation to shift the culture away from relying on that. And with that, I do have one 60-second question that will hit the recap and be done for today. What about tramadol? So like I have personal bias against this medication, but I feel like there are plenty of patients who come in on tramadol because their emergency doctor, their PCP, their whoever is using it as a cop out. Like, oh well, I know I'm not supposed to do oxy or hydrocodone, but here's some tramadol. And like I feel that 100% of those patients come to the ER. Not an accurate statistic, but how it feels. Like talk about tramadol as our last like 60 seconds. What do we need to know about tramadol?
Tramadol is an opioid. It's a murky medicine of an opioid. It's still an opioid. So don't use it to bypass a complicated conversation. If you want to use an opioid, make your heart in it and pick a full agonist opioid. If you are saying, hey, this patient's kind of dangerous for an opioid, don't use tramadol as that like, woo, it's not really an opioid. It is an opioid. It is dangerous. It has side effects. And either choose to use a full opioid agonist and discuss the risks and benefits, or choose buprenorphine or choose other pain modality, but don't get around it by calling it tramadol and not having a conversation in a full thought.
Okay, so it is a cop out. I'm not just like guessing that that's the case. Okay, so I'm going to do my best to recap everything we just talked about. Again, realizing that for me, a lot of this was new information, and I really cannot thank the two of you enough for imparting your passion and your hearts and your brains on this subject matter for all of us. But so basically, first and foremost, yes, buprenorphine is a safe, viable option for treating chronic pain. And in fact, it's probably a good option for treating acute pain. We just don't have access to the correct dosages here in the US, those like microgram based doses for people who are opioid naive. So hence we don't see it, but other countries are doing it. It's probably coming to an America near you sometime in the future, and that will be neat. But for now, great option for chronic pain. Every clinician can prescribe it, right? There's no X waiver. You don't have to go to a methadone clinic every day. Patients can have a prescription that's going to be done by a family practice doctor, an emergency provider, a hospitalist at discharge, OBGYN, pediatrician. Like literally, if this is what you're dealing with, anybody can prescribe it. You know, think about getting the films, the combination like Suboxone, buprenorphine, because they can be cut into different doses, gives your patients a bit more flexibility. But the pill version, the film version, it all works. So it doesn't really matter which one you're using, but there might be some practical benefits. If a patient is already on bup and in acute pain, do not stop their buprenorphine. Keep it going, but think about dividing that dose up, because we get the rise and fall of the analgesic effects a bit more short term, as opposed to the long half-life for treating opioid use disorder, withdrawal, cravings. And so think about dividing up that dose. Same with chronic pain patients. They might do great on bup, but they need smaller doses more frequently. Do not forget your multimodal analgesia. Pain treatment is a pyramid. Start with the holistic approach, the things that aren't medicine at all. What is the root cause of your pain? Maybe it was an injury. Maybe it's loneliness. Maybe it's that you're not moving around enough and you need movement. Maybe it's physical therapy that you need. Maybe it's ice and heat and laughter and movies that you like and coloring books. And then add on layers so that the opioid is the top layer for severe chronic breakthrough pain on your chronic pain. Not that every day I take this all the time, no matter what. Mentality. And some patients might still do that, but it's how we discuss and educate our patients, and that onus is on us. And of course, practicing that empathetic language, that they understand that our goals are the same, but identifying those goals out loud so that no one thinks that the idea is pain-free and high all the time. That's not what we're going for. We're going for functional, happy, able to sleep, able to move, able to enjoy your life. And then not forgetting those psychosocial services that your patients might need to be able to augment their holistic approach to treating their chronic pain. Okay. Remember that pain contracts are not particularly helpful. It's much more important that you have a good relationship with your patient, that you can talk to the human in front of you, so that things like, for example, urine toxicology screening are not how we're deciding how a patient is doing. Our conversation with the patient tells us how the patient is doing. And if you currently work in a clinic setting where they mandate those toxicology tests, think about, is there a way to do it that's more patient-centric? Could patients have open discussion about that test and actually consent to it or decline it? Could you do a bedside version that doesn't get input into the medical record to be seen by everybody everywhere, because it might carry negative consequences that aren't fair? Like, is there a more patient-centered way that you could use that test as a conversation piece and a monitoring piece, more than a gotcha piece that comes with a lot of, you know, downstream consequences we may not be aware of? And then when it comes to things like tramadol, don't use it as an excuse. If you're gonna do opioids, do them, but just do it appropriately. Think about the risks for your patient. Talk to your patient about it. Make sure that they're a part of this, you know, chronic pain treatment journey with you. It's a teamwork thing, and that is true for switching them to buprenorphine or not. That is true for increasing their dose or not. That is true for so many components of their care. So That's a wrap. I think I didn't misspeak. I'm looking at some nodding. Okay, good. I didn't biff. So a couple of just quick things. If you're trying to do this for one of your patients and you can't remember what the heck we just said and you're like, oh my God, I'm stuck, I'm whatever, call the UCSF warm line. This can be reached from anywhere across the nation. It runs from on Pacific time. You can leave a voicemail, they'll call you back. It's free. It's a great service for clinicians, especially if you have a specific patient that you need help with. And then don't forget that we have tons of resources on the California Bridge website that are really helpful. All of the clinical protocols we reviewed are on there. And then we do have the California Bridge Academy. So if you're looking for the quick start guide, more details on long-acting buprenorphine injectables, treating acute pain, any of that, we have full separate lectures about that. All of it's free always. It's done by our amazing team and guests that we love to invite. And if you have any other questions for us, you know how to reach us, info@bridge2treatment.org, info@bridge2treatment.org. And I just want to say thank you one more time to Sunny and to Rebecca, these amazing women doctors out there taking great care of their patients and helping all of us do the same. And I want to thank all of you for everything that you are doing to help us to save and improve lives. Have a great day.